Greetings. Let me share with you endoscopic therapeutic options for peptic ulcer bleeding based on my reading of the latest guideline from the American College of Gastroenterology published in 2021. So, what are all the various endoscopic options that we have? You could divide them into two different sets. Those that require the use of heat by employing bipolar electrocoagulation or direct heat with a heater probe, or applying heat using a gas, that is argon plasma coagulation, and applying heat with soft coagulation setting. So these are all the various ways that you deliver heat to coagulate the blood vessel and stop bleeding. In addition, one could also use injection of a sclerosant like alcohol, or the use of a vasospastic agent like epinephrine, applying mechanical hemostasis with deployment of through the scope clip, over the scope clip, or applying a hemostatic agent with delivery of hemostatic powder. So we have several different options that we could use, and let me take you through step by step how each one is used in the management of a patient with peptic ulcer bleeding, and what evidence do we have, and what are the recommendations by the American College of Gastroenterology in terms of the strength of recommendation and the quality of evidence that is available. So let us start with bipolar electrocoagulation. And this involves the use of a probe that you pass through the endoscope channel, and the technique involves the use of a probe, preferably a large probe with a diameter of 3.2 millimeters and a setting of 15 watts for 8 to 10 seconds of firm to maximal pressure to occlude the vessel and coagulate and seal the vessel. Bipolar coagulation of active bleeding ulcer has been shown to reduce bleeding and also reduce mortality in studies published in the literature. What about the American College of Gastroenterology recommendation about this treatment? They give a strong recommendation based on moderate quality of evidence. Next, let us talk about another therapy that applies heat, that is heater probe therapy. Again, the technique involves passing a probe through the endoscope, preferably a large caliber probe of 3.2 millimeters in diameter, with delivery of 30 joules for 8 to 10 seconds, and again using firm to maximal pressure to occlude the vessel and then seal the vessel with heat. Again, this treatment, the heater probe therapy, has also been shown to reduce bleeding and reduce mortality. And the quality And the quality of evidence is also very good, and the recommendation is a strong recommendation based on moderate quality of evidence. In the same group, you have another modality, that is injection of sclerosant. And in this one, you use an injection needle to inject a sclerosant. And let us look at the technique. Use absolute alcohol, 0.1 to 0.2 ml per injection to a maximum of 1 to 2 ml. That's the maximum ml that you could use. Beyond that, there is a risk for perforation. And again, this therapy also has been shown to reduce bleeding and also reduce mortality. And the American College of Gastroenterology gave strong recommendation based on moderate quality of evidence. So, up to now, we reviewed bipolar electrocoagulation, heater probe, and injection of alcohol. All of them have very good, strong recommendation for therapy because they've shown to reduce bleeding and reduce mortality. And the evidence is also moderate quality of evidence. So next, let us look at some of the newer techniques that have become available in the last 10 to 15 years. These include clips, and the technique involves passing a clip through the scope, and you clip over the bleeding site, and if there is a space available, clip on either side of the bleeding site to catch the bleeding vessel. And this technique has been shown to reduce bleeding. The American College gave conditional recommendation based on very low to low quality of evidence. Next, go to soft monopolar coagulation. In this technique, you pass a monopolar coagulation forceps and use soft coagulation, not forced coagulation. Soft coagulation, the depth of injury is pretty limited to the vessel, and the settings are 50 to 80 watts, and apply 1 to 2 seconds. This technique also has been shown to reduce bleeding. Conditional recommendation with very low to low quality of evidence. Next, let's move on to organ plasma coagulation. And the technique involves passing an organ plasma coagulation catheter, preferably a forward jet catheter, and you set the flow rate at 1 to 2 liters per minute and a power setting of 40 to 70 watts, keeping the probe 2 to 10 millimeters away and delivering the organ plasma coagulation. And this also has been shown to reduce bleeding. Conditional recommendation based on very low to low quality of evidence. Next, over the scope clip. And in this one, you place a clip over the scope, end of the scope, and you take the scope loaded with the clip, reach the lesion, and approach the lesion en face, and place the cap over the lesion, encircling the bleeding area. Suction the lesion into the cap, and then release the clip to deploy the clip onto the bleeding site. This has been shown to reduce bleeding and conditional recommendation with low quality of evidence. Next, hemostatic powder spray. So this involves inserting a catheter that delivers the hemostatic powders, and this is as TC325 material, and you pass the catheter to the bleeding site and keep the catheter tip 1 to 2 centimeters from the bleeding site and apply the powder in 1 to 2 second bursts until the bleeding stops and the area is fully covered with powder. This has been shown to reduce bleeding and conditional recommendation with very low quality of evidence. Now, let us look at the role of injection of epinephrine, which has been used by many. And you pass an injection needle and use epinephrine 1 in 10,000 dilution and inject 0.5 to 2 ml per injection at the bleeding site. And the maximum volume has not been determined. Typically, endoscopists have used 8 to 10 ml. In some centers from the Far East, they've used even higher volumes of epinephrine. This has been shown to reduce bleeding, but the bleeding recurs. Hence, you should use epinephrine injection not alone, but in combination with either heat therapy with a bipolar probe or with the help of a heater probe, or a mechanical device such as a clip. The college recommends using epinephrine alone against the recommendation, but epinephrine in combination with either delivery of thermal modality or a mechanical modality, and strong recommendation with very low to moderate quality of evidence. So we talked about endoscopic hemostasis, and we covered different options, and the best options with the best quality of evidence and strong recommendation includes the use of a bipolar coagulation or heater probe, and sclerotherapy as also comes in the same group. And we've also covered other modalities that have been shown to reduce bleeding with a conditional recommendation. However, using epinephrine injection alone without additional therapy is not favored, and something to keep in mind. So I hope this brief overview of various options for peptic ulcer bleeding is useful to you. In the future, we will go into some of the details about how to manage bleeding using each of these techniques. Thank you.